Hello everyone, my name's Gage. I'm a medical student and I wanted to put together a couple of videos for you guys to integrate a lot of topics together for your Step 1 exam. Okay, and so the traditional way that we study medicine is that we study it very linearly. We study cardio, we study resp, we study GI, all these different organ systems, and we study the basic sciences as well, and we study them all very linearly. Okay, we go through them all kind of like this by organ system. In order to master Step 1 material, and do very well in this test, and even, clinically as well, is that we need to be able to go through these organ systems sort of like this, more horizontal fashion, in order to cover things that affect all of these systems together, because all of these systems are very interrelated. Okay, and so one thing I did while studying for the exam was I made notes that combined everything on a particular topic in one set of notes. And that sort of helped me pull and integrate different topics together. And I think one really good way of doing that is to start with a really cool molecule in medicine and in the body called hemoglobin. Okay, and so that's what we're going to do. We're going to talk about hemoglobin, and we're going to integrate lots of different topics from many different organ systems at the same time when we talk about this molecule. Alright, so let's get started by talking about hemoglobin by looking at the word itself. Okay, I'm all about not having to memorize as much as possible and to just know what things are, based on their context. Okay, and so a good way to do that is to look at the word hemoglobin, and we see that it's got two parts to it, and that's exactly what hemoglobin has. It's got a heme group, and that carries the iron, and it's got a globin group, and that is the protein scaffold. Okay, and that's really all that hemoglobin is. It's just these two different proteins put together in order to form the bigger molecule. And you can say that the ratio of heme to globin is a 1-to-1 ratio. Okay, for every globin there's one heme. Okay, and there ends up being 4. Okay, so there's 4 globins, which means there's 4 hemes. Okay, and these different globins, you can have different kinds of these globins. Okay, in an adult hemoglobin, we just happen to have alpha and beta, and we're going to have 2 of each. So we're going to have 2 alpha, 2 beta globins, and that is going to form the standard type of hemoglobin in adults called hemoglobin A. Okay, there's different types of globin chains that we'll look at as we go through, and that'll be something to look at later on. But heme is always the same. They always have the same molecule of heme in the globin chain. Okay, and so in the USMLE, what's important for you to know is how heme is constructed, whereas the globin is not as important to know how that's made. Okay, so the main use of hemoglobin that we'll talk about is in red blood cells. Okay, so in red blood cells, the heme part is used to carry on the oxygen. Okay, and that comes up really importantly in the respiratory system when we talk about the ability of hemoglobin to carry oxygen. Okay, and so that'll play in, its structure will play into how we'll talk about the physiology of hemoglobin later on. Okay, so that's one of its major uses, is in the RBCs. The other major use that gets a little bit less credit but is equally important is in the cytochrome P450 system. Okay, and that system these are liver enzymes. Okay, and we use them other organs as well, but mainly in the liver. Okay, and these are going to use heme as a mode of carrying out enzymatic reactions. Okay, and so that's another very important use of heme. So if you had to argue, where in the body is heme made, it's made in our RBC precursor cells. So in our early red blood cell forms, you're gonna be making heme in those cells, and then you're also going to be making it in the liver very frequently for this cytochrome P450 system. Alright, so let's zoom out a little bit and look at my drawing of hemoglobin just really quickly as sort of you can have a little mental image in your head of what hemoglobin actually looks like, and you can Google it obviously for a better picture. This isn't the best one, but you see here that the yellow, I'm going to label those as alpha. These are going to be our 2 alpha chains, and the blue is going to be our beta chains in our normal adult hemoglobin. And then these little red diamond shapes with the gray in the middle, those are going to be our heme molecules here in the middle. Okay, so these are going to be where the oxygen gets carried. Right? So when we talk about hemoglobin, obviously we said that the normal adult hemoglobin is hemoglobin A, okay, and that it consists of 2 alpha and 2 beta chains, but there's a lot of different types of hemoglobin, so let's take a look at some of those now, okay, so I've listed out, the most clinically relevant or the most step relevant different types of hemoglobin, okay, and at the top, obviously, we have our hemoglobin A, which is normal adult hemoglobin. Okay, and that saying that normal adult hemoglobin is important, right? Because if we look down a little bit farther here, we'll see that hemoglobin actually takes a lot of different variations throughout development. Okay, and so in the yolk sac, which is in the very beginning of life, we have a different type of hemoglobin. In the yolk sac, we have hemoglobin with epsilon 2 and zeta 2. And remember, these are the globin chains, okay? And this isn't the type of hemoglobin that's very clinically relevant. This is very transient, only lasting about 6 weeks. Okay, and then hematopoiesis, or that's the process of making red blood cells, is going to move around. So in the beginning, it takes place in the yolk sac. Okay, and then we're going to move to the liver next. Okay, and in the liver, we're going to make a different type of hemoglobin, and this one is very clinically relevant. We're going to make hemoglobin alpha 2 gamma 2, and this is hemoglobin F. Okay, and that stands for fetal. Okay, so if we look at that F, it stands for hemoglobin fetal. Okay, and this hemoglobin is very important. It's clinically relevant in a couple of different types of diseases, but the important part about this is that it has a decreased affinity for a molecule called 2,3, BPG. Okay, and that's 2,3-bisphosphoglycerate or 2,3-diphosphoglycerate. You may see it either way. Okay, and the important part about that is that this makes the hemoglobin alpha 2 gamma 2 have a much higher affinity for oxygen. Okay, higher O2, grabbing ability. It's going to grab that hemoglobin and it's going to grab that oxygen from the maternal circulation. Because if you think about the fetal circulation and the maternal circulation, mom is pumping blood around the placenta, but baby needs to get that oxygen. She needs to pick it up from mom. And if baby is going to be able to steal the hemoglobin away from mom's hemoglobin, the baby is going to need to have a hemoglobin that has a higher affinity for oxygen than mom's hemoglobin. And that's the whole point behind this fetal hemoglobin here, this alpha 2 gamma 2. Okay, and so that's very important to think about as well. And at the same time here in the spleen, we're also going to have alpha 2 beta 2 being made. And this is our regular adult hemoglobin, so the body, is just trying to practice making adult hemoglobin. We need to have some floating around, because once you get to the point where the baby is born, you need to have that adult hemoglobin hanging around in order to participate in respiratory exchange when baby finally starts breathing. Right, and then, our hematopoiesis, the construction of our red blood cells, that's going to move over to the bone marrow, and the bone marrow is going to make alpha 2 beta 2 as well. Okay, so that's just a couple little intro things about the embryology of hemoglobin, which is very important to think about, and it's very clinically relevant as well. Alright, so that's hemoglobin A. Alright, and then you have all these different types of hemoglobin, and this looks like a very daunting list, but let me simplify just a little bit and sort of break this up like this. I think this is a really good way of thinking about it. Alright, so these first two are problems with the alpha chain, okay, of hemoglobin, the alpha globin molecule. Okay, these first two problems here. So this is going to be hemoglobin H disease and hemoglobin Bart's. Right, these are both hemoglobin types that you get in alpha thalassemia. Okay, and alpha thalassemia is a problem in the construction of the alpha globin chain. Okay, so in hemoglobin H, we're going to get 4 betas, and in hemoglobin Bart's, we're going to get 4 gammas. All right, and so the problem in alpha thal, if you don't have any alpha chains and you have this gamma 4, that's going to be incompatible with life. Okay, so these organisms are not going to be able to survive with hemoglobin Bart's. All right, alpha thal 3 times. If you have 3 of the alpha genes mutated out of the 4 total, then you're going to get hemoglobin H disease, and this is a severe disease, but it's not as severe, obviously, as hemoglobin Bart's. You can survive with hemoglobin H disease. Okay, the next group of 2 we're going to have is the beta thal problems. All right, so these are going to be beta thalassemia. All right, that's hemoglobin A2. Remember that our regular hemoglobin adult is hemoglobin A. This is a problem making the beta chain of hemoglobin. Okay, that's beta thalassemia, and it's just as simple as that. We have a problem making that beta chain, and so we're going to get a little bit something else. We're going to get alpha 2, we're going to get delta 2. All right, that delta globin is just a substitute that the body will make for the beta globin chain. All right, and that's beta thal minor. All right, beta thal major is a little bit more clinically relevant. In beta thal minor, we're still making some beta globin, so you're going to have some A2D2s. We're also going to have some A2B2s as well. All right, here it's going to be a mix of these two. But in beta thal major, we don't really have any beta globin being made. And so we're going to have to stick with alpha 2 gamma 2, which remember we just talked about was hemoglobin F, hemoglobin fetal. So our body is really accustomed to making this alpha 2 gamma 2, okay, in the fetal circulation. And so we're going to have to revert back to that, when the body discovers, hey, we can't actually make this beta globin chain. Okay, and this is not ideal for a number of reasons, is that this hemoglobin has a really high oxygen affinity, and it's not going to be able to give up its oxygen as easily as other types of hemoglobin, and so this is going to result in some tissue damage and anemia as well. All right, we'll talk about that more when we talk about thalassemias. The last two are sickle cell and hemoglobin C disease. These are sort of another little category that can be problems with hemoglobin. Both of these are going to be mutations in the beta chain, all right, but more importantly, they're mutations at actually the exact same point, and that's the 6th amino acid of the beta globin chain. Okay, normally that amino acid is a glutamate. And we abbreviate glutamate as an E for its single letter amino acid. All right, and glutamate, or glutamic acid, is an E, and that's an E at the 6th position. All right, and that gets substituted. And in sickle cell, it's going to get substituted for valine. All right, so the shorthand to write this out is going to be E6V. Okay, this is an E6V mutation in the beta globin chain. That's what I want you to think when you think about sickle cell. E6V in the beta globin chain. All right, and that in sickle cell, that's going to cause these hemoglobins to sort of cluster up and form this weird clump inside the red cell, and that's going to form the whole superstructure of the red cell to change shape into these little sickles, type shapes, and these shapes are going to get stuck in blood vessels. All right, so that's the pathophysiology essentially of sickle cell disease, all right there. It's very simple. Right, hemoglobin C disease is actually, strangely enough, is a mutation in the exact same point, right? But it's going to be an E6 or a glutamic acid at the 6th position, and it's going to get substituted for lysine. And remember that lysine's single amino acid abbreviation is K. All right, I'll draw a little LYS for lysine. All right, and so this isn't going to be as big of a problem for the hemoglobin. All right, this is still, a mutation. It's still going to warp the hemoglobin. It may not be as good at carrying oxygen, but it's not going to sickle like in the sickle cell diseases. All right, so that's the important things about these intro types of hemoglobin to think about. Okay, and this list unfortunately takes a little bit of memorization, but try to always write them out in the same order and group them. Okay, if you can group things in your mind, it's a lot easier to think about. Okay, so the first two types are alpha, the second two are beta, and the third pair are mutations at the 6th position. Okay, and there you go. You've memorized all of your different types of hemoglobin. All right, so now let's move on to the heme synthesis pathway. All right, I've sort of drawn a skeleton of the pathway here for us to look at. We're going to move through these steps individually and work through this pathway, all right? And so nobody likes biochem, and I understand that. And it's sort of tricky to get through all these different pathways. There's so many of them, okay? But a couple tips for you guys as you work through a lot of these pathways is to do them always the same way. All right, so always draw the pathway the same way. This is how I drew it, and I find this really helpful. All right, because when I think about this pathway, I think about, the heme synthesis pathway, that's the one that I drew a U shape. Well, why did I draw it in a U shape? I drew it in a U shape because it starts in the mitochondria, and it ends in the mitochondria, and in the middle it goes into the cytosol for a little while. Okay, and so that sort of helps me remember that, and then I can remember the starting point and the end point a little bit better. And the more you think about it, the more you can remember different aspects of the pathway by always doing it the same way. Right? It helps you visualize, and that's very important. All right, another way to make this pathway a little more exciting is we're going to add some intrigue. We're going to add a little bit of interesting stuff to this pathway to sort of make it a little bit more fun. Okay, and I promise that there's a couple things about this pathway that are actually very interesting and sort of relate to a little bit of cultural mythology as well. And so I'll sort of leave you in suspense about that, and we'll get started by looking at the first step. Okay, so we start off in the pathway with glycine and succinyl-CoA. Right, and that's important to know because a lot of these pathways start off with different molecules, and a lot of questions will want you to know or be able to identify, what molecule started off a pathway. All right, so for this pathway, we're going to start off with two fairly generic molecules. We're going to start off with glycine, which is an amino acid. Okay, and so from here, if you didn't want to talk about this pathway anymore, you could get totally distracted and you could talk about amino acids, and there's so many different types, and there's so many different places that these amino acids are important. Okay, and so that's one thing to talk about. Another thing you could talk about is gastrointestinal system. Where are these things absorbed? How are they absorbed? How do the proteases break them down? What are the different kinds of proteases? Where do those proteases come from? What are the different kinds, and how are they activated? Are all important things to think about. Okay, so that a lot of these proteases are going to come from the pancreas. That's one good place to come from. And if you had some pancreatic insufficiency, how would that affect the way that you absorb some of these different molecules? So that's a good thing to think about as well. All right, so the other thing we're going to have here is succinyl-CoA. And succinyl-CoA is actually a very common biochemical intermediate. All right, and one of the places that we're going to get succinyl-CoA from is alpha-ketoglutarate. And if you've done your biochem already, you'll know that alpha-ketoglutarate actually comes from the TCA cycle. And where does the TCA cycle come from? Well, that comes from, glycolysis. And what do we put in glycolysis? That's where we put in our glucose. All right, so glucose can actually get made into the succinyl-CoA. All right, the TCA has a lot of different intermediates, a lot of different things that can feed in. Okay, the TCA, but the end result here, for our purposes, is that we're going to get succinyl-CoA from it. All right, and one of the important things to think about here is we always want to know in biochem what are our cofactors and what are things that we put in. Right, and our cofactor that we're going to use here is called thiamine. And thiamine is a very important cofactor for a lot of different biochemical reactions. All right, and remember that our the pathology that relates to thiamine is that alcoholics, forgive my spelling, alcoholics are going to be very deficient in thiamine. All right, and so we're going to always want to supplement this patient population with thiamine. Even people who have a very poor diet are going to be deficient in thiamine. Right? And this is just one of the many ways in which thiamine can have an effect. Okay, a lack of thiamine can have an effect on what we use for our chemical pathways. All right, so the other place that we can get succinyl-CoA from is from methylmalonyl-CoA. Right? And the important thing to think about here is that where do we get methylmalonyl-CoA from? Well, we get it from propiononyl-CoA. Well, that's not really an answer. So where do we get propiononyl-CoA from? We're going to get it from odd-chain fatty acid metabolism. Okay, that's an important place we're going to get it. We're also going to get it from homocysteine metabolism. All right, and the last place we're going to get it from is amino acid metabolism. I'm just going to abbreviate that AA. Metab. All right, so this is where we're going to get our propiononyl-CoA from. All right, so this is just another little way that we can get methylmalonyl-CoA and eventually succinyl-CoA. And again, what is our cofactor for this reaction? Well, it's going to be B12. All right, and as if B12 didn't have enough to do, with heme, and sort of these blood vessel things, here we have it in another place as well. All right, and so lack of B12 is going to produce a lack in heme synthesis. Not only is it going to affect nucleic acids and how we can make those, it's going to affect our heme synthesis pathway as well. All right. So that's just a little sort of teaser intro into where we got our glycine and succinyl-CoA from, and I really would challenge you to sort of branch out and review some of these other topics because all these things are very interrelated, and knowing how some of these things affect each other is very important. Alright, so our first enzyme in the pathway is going to be an enzyme called synthase. And whenever you see a synthase, whatever comes after that enzyme is typically what that enzyme is named. Alright, so we know that our next molecule is going to be delta aminolevulinic acid. We're just going to abbreviate that DALA for now. I'm just going to keep calling it DALA because that's a little bit of a mouthful. Alright, and so you see a couple little lines, little inhibitors on this DALA synthase, and these are going to be very important. And why do we have all these inhibitors here? Well, the reason we have them is because this is the RLS. This is the rate limiting step. Alright, and I don't want you to start cringing because I know everybody hears rate and they start thinking about this Michaelis-Menten and these complicated enzyme kinetics. You know, the bottom line for you guys and the bottom line for any biochemical reaction with a rate limiting step that we talk about is control. Alright, this is what's important. This means that we have control over this step in this pathway. Alright, because we can use glycine and succinyl-CoA for many different things in the body. You know, if we couldn't do heme synthesis, we could use glycine for all different kinds of stuff. We could use succinyl-CoA for all different kinds of stuff. But once we start getting into DALA, delta aminolevulinic acid, we can't use that for other stuff. We can only use that for heme synthesis. Alright, not only that, we're also going to have trouble breaking this down if we don't have DALA going all the way through the pathway and finishing at heme. We're going to have a hard time with this molecule just sort of hanging out and accumulating in the tissues, and that's not going to be bad. And we actually have some pathologies that are going to relate to that. Right? So a couple inhibitors of DALA, well, most intuitively, one of those things is going to be heme. Right? That's a very, very common biochemical element, a common theme in biochem is that heme, or the final pathway, the final product of the pathway, is going to inhibit the beginning of the pathway. Right? So this is very important, not only just because it's a very common biochemical thing, but also because we're going to actually use this to our advantage later on. I'll leave you with a little bit of a cliffhanger on that. Another thing that's going to inhibit this pathway is ETOH. Our alcoholics never get a break in medicine. They always have something wrong with them, and this is just the next thing that's wrong, with alcoholism. All right, so alcohol is going to inhibit this enzyme. Another thing that's going to inhibit this enzyme, weirdly enough, actually, is glucose. All right, so glucose itself is going to inhibit this enzyme. All right, and the reasons behind that are not actually very important, but the fact that glucose can inhibit is going to be important for your exam. All right, now we have a cofactor here. You can see I've drawn a little line in yellow, and yellow in this drawing is going to be cofactors. All right, and this is one of the biggest cofactors that we're going to talk about in biochem is vitamin B6. All right, so now I want to take a little bit of a tangent and talk about vitamins just a little bit. B6 is pyridoxine. All right, or as it becomes later, PLP, pyridoxal phosphate. That's going to be important. All right, so for our purposes, pyridoxine, PLP, and B6 are all the same thing, even though chemically they're a little bit different. For our purposes, we want to know that all those are the same. All right, and what again are our water-soluble vitamins? Water-soluble vitamins are going to be our B's and C's. All right, what are our fat-soluble vitamins again? These are going to be A, E, D, and K. All right, so that's an important thing to think about. We have a lot of different types of B vitamins. We only have one vitamin C. All right, but we have a lot of different types of Bs, and this is B6. All right, you definitely want to know the names of all these B vitamins. Now, I won't list them out here, but you want to know all the names of those B vitamins. All right, so whenever you think about a vitamin, there's a couple things I want you to think about. You want to think about deficiency, right? And what that deficiency looks like, okay? And we want to think about where do we get it from, so the source. All right, so deficiency in B6, what can cause a deficiency in B6? The chief thing and the biggest thing for you, the most high yield, is going to be isoniazid. What is isoniazid? That's an MTB drug, Mycobacterium tuberculosis drug, that we're going to use to fight tuberculosis. We can also use it to fight other infections as well, but we're going to mainly use it for tuberculosis. All right, and if you want to be smart and you want to sound smart in front of your clinical physicians, one thing that you can say whenever a patient has been prescribed isoniazid is that you also want to prescribe pyridoxine. All right, you always want to give these two things together because isoniazid is famous for causing B6 deficiency. All right, so that's one thing that can do it. Other things that could do it, of course, if you don't eat enough. So dietary deficiencies, people with poor diet, that tea and toast diet that I sort of talk about in questions in the elderly. Another thing that can cause it is our anticonvulsant medications. That's going to be phenytoin, okay, and carbamazepine. These are going to be important for causing B6 deficiency. They cause decreased uptake of B6 in the GI tract, and the mechanism behind that isn't very important. All right, just the fact that is what happens. All right. Anticonvulsant medications have a lot of side effects, and this is just one of them. Okay, where are we going to get our B6 from? Well, this is kind of a fun way to remember it, is that this is our meat and potatoes. All right, meat and potatoes, that's where we're going to get B6 from. Meats and potatoes. All right, so just try to remember that. Meats and potatoes is where we're going to get our B6. All right, so let's move on in the pathway and start talking about what we're going to do next. All right, so I mentioned earlier that right now we're in the mitochondria, and that's very important to make sure you locate yourself and sort of keep an eye on where we are, all right, because a lot of questions will frustrate you by challenging you where the molecule is in the cell, all right, where this pathway is taking place. All right, and this one actually crosses the mitochondria and goes out, so we're going to start in the mitochondria, and that's convenient. Okay, starting in the mitochondria is convenient because where does TCA cycle take place? Where does chain fatty acid metabolism take place? All right, those are going to take place in the mitochondria. All right, so that's where we're going to get our starting molecules from, and that's important to think about. All right, so now we're going to move our DALA molecule, our delta amino levulinic acid. We're going to move it out into the cytosol. We're going to start with porphobilinogen. All right, so the enzyme that's going to make porphobilinogen is going to be called D-ALA dehydratase. All right, so this is the dehydratase. This is the first enzyme that we're going to have in the cytosol for this pathway. And you see that we've got a little inhibitor for this pathway. And what's going to inhibit D-ALA dehydratase? Well, it's going to be lead. All right, so this is definitely a huge component of lead poisoning, and definitely leading up to our end result, sort of our big conclusion on this pathway. All right, is going to be lead. All right, we'll revisit this again in a little bit. All right, so porphobilinogen is going to be our next molecule. It's going to get made into hydroxymethylbilane by porphobilinogen deaminase. All right, so look, so far we have a synthase, we have a dehydratase, and we have a deaminase. All right, and that reaction, the way that reaction happens is not very important, but what is very important about this reaction is the pathology that results. All right, I've sort of left it blank. And now it's time for the grand reveal. This is going to be acute, intermittent porphyria. Alright, and then the name tells you a lot about this disorder. It's acute, that means it happens quickly. It's intermittent, which means it's on and off. Alright, and it's a porphyria, which means pathology with the heme synthesis pathway. Alright, for every disorder, or every disease that you learn about in medicine or for step one, there's 5 things that you should know about every disease, and there's probably more than these 5 things to know about a lot of other diseases, but for these are the 5 things to know. All right, the pathophysiology is very simple here. It's a porphobilinogen deaminase deficiency, and whenever you have a deficiency of an enzyme in biochemistry, the pre-existing molecule builds up, and that's porphobilinogen. Right, and this is going to be tissue toxic. All right, the other problem that we're going to get as part of our pathophysiology is a decrease in heme production. All right, a decrease in heme production as well. All right, so signs and symptoms of this disorder, we sort of have a pentad here. All right, so 5 things, and a lot of them start with P. If that's something that you want to remember, then that's the way that you want to remember it. I think that's okay. I don't like mnemonics with a lot of the same letter, but that's one way to do it. So one of our signs and symptoms is going to be abdominal pain. Alright, and this is going to be sort of a diffuse abdominal pain that's sort of all over the abdomen. It's not really localized, it's just pain in the abdomen. Okay, the next thing we're going to get is port wine urine, so this is going to be dark urine. Alright, it could be even mistaken for blood. Alright, so if you get a question in the patient and the question is sort of talking about how their urine has blood in it, when the patient says that, you want to take that with a grain of salt. Could be blood, could also be something else. Alright, and in this case it could be a porphyria. I don't know if you guys watch Scrubs, but in Scrubs, acute intermittent porphyria is diagnosed when the patient's urine is left out and it actually changes color, and it will do that in response to UV light in acute intermittent porphyria. Alright, so that's one possible way to diagnose it, and that's one possible sign of it. Alright, so the next thing that we'll think about is polyneuropathy. Polyneuropathy is a fancy term for just neuropathy in multiple sites. So you're going to get tingling of the limbs, weakness possibly, sensory deficits are very commonly reported. Alright, so the next thing we're going to get is psych disturbance. Psych is another fancy term for altered mental status. These are patients that are not going to be alert and oriented. AOO, we say AOO times 3 for alert and oriented to person, place, and time. Alright, you can say AOO times 4 sometimes as well if you add an extra element in there. But anyway, so these patients are not going to be alert and oriented, alright, to where they are, who they are. They're going to be altered in some way, altered in personality, alright, and this again is going to be an acute and intermittent problem. Alright. The fifth thing about it, the fifth P, is that it's precipitated by drugs, and specifically, these are going to be precipitated by P450 stimulating drugs. Alright, so this is immediately obvious if you remember that the P450 system uses heme. Alright, so if we use a drug that stimulates the P450 system, we're going to need more and more heme. That means we're going to be running this pathway. We're going to be running this pathway more and more and more. And if we run this pathway and we keep running into this roadblock, this porphobilinogen deaminase problem that's not there or is not in the quantities that it's needed to run the pathway, then we're going to build up more and more porphobilinogen. We're going to build up porphobilinogen more and more, and that's going to increase the neurotoxicity problems that we have with this molecule. Alright, so remember there's some specific drugs that stimulate the P450 system. The mnemonic I used for this was GCPBR, SC. Alright, so griseofulvin, carbamazepine, alright, phenytoin, barbiturates, rifampin, St. John's wort, chronic alcohol. These are all things that can mess with our heme, this acute intermittent porphyria problem. Alright, so griseofulvin is an antifungal. Right, carbamazepine is our anti-epileptic medication. Phenytoin similarly. Right, barbiturates, some sedative medications that we don't really use very often anymore. Rifampin is again for MTB, Mycobacterium tuberculosis. St. John's wort actually is a very interesting sort of natural molecule that functions as an SSRI, a serotonin reuptake inhibitor, that can be used in depression. It's actually very effective in depression. Chronic alcohol is the other thing. So chronic alcohol is going to upregulate the CYP450 system. Okay, and other things that you may see on test questions more than real life is going to be OCP and ginseng. Alright, ginseng is that thing that is commonly in teas. It's sort of an herbal supplement. Alright, so those are some things that are going to mess with our acute intermittent porphyria. Those are our signs and symptoms. The way we're going to diagnose this condition is with porphobilinogen in the urine, and that makes complete sense given the pathophysiology. You understand the pathophysiology, you understand that a porphyria, urea in the name, is going to mean that we're going to have these molecules building up in the urine. Alright, we can also do gene analysis, and the gene in particular is not important for step 1. Alright, so treatment is going to be glucose and hemin. And remember, if we go back and talk about, what inhibited our D-allele synthase, that was heme. That was a big point of what we talked about. Also glucose as well. Right? And those two things are going to inhibit the synthase. If we're inhibiting this point in the process, then we're not going to get that porphobilinogen built up because we've stopped the pathway prematurely. Right? We're not going to get that porphobilinogen built up, and now we get to sort of stop this acute intermittent porphyria attack. Hemin is essentially heme. Alright, so don't get twisted up in what these things are. These are just oxidized heme. Alright, and so that's what hemin or hematin is. Alright, complications of acute intermittent porphyria is going to be anemia. Alright, that's going to be our complication. You know, we're not able to make heme as productively as we want, and that means, you know, our hemoglobin is not going to be as plentiful, and that means that our red blood cells are not going to have as much, okay, and that often results in anemia, alright? So let's keep moving on down the pathway. Fortunately for us here, we get to skip a couple of enzymes here. So once we get hydroxymethylbilane, we're going to move on to uroporphyrogen 3. Alright, no important enzyme there. Alright, and then now we get to move into coproporphyrogen 3. And our enzyme here is going to be uroporphyrogen decarboxylase. Alright, so remember, if you're having trouble with these enzymes, you know, a suggestion I have is that you should remember the last name. Alright, the last word in all of these enzymes. Alright, so synthase, remember synthase, dehydratase, deaminase, decarboxylase. Alright, all these enzymes are doing different things, and it's good to, if you're having trouble remembering the different precursor words in these enzymes, the first word in the enzyme, remember the last word, and that might help you out a little bit, at least to get started. Alright, so this is going to lead us to our second porphyria, and actually, fortunately for all of you guys, the last porphyria, so this is great. Alright, so this one is a deficiency of uroporphyrogen decarboxylase, and this is porphyria cutanea tarda. Porphyria cutanea tarda. Alright, and actually I think it is EA. So porphyria cutanea tarda, and this again tells you kind of what we've got going on here. We've got porphyria and we've got cutanea, alright, and that means it's going to affect the skin. Alright, and that's the really, you know, if you had to only remember one thing about this, that's what I want you to remember. Alright, this is the most common porphyria, right? MCC, most common cause of porphyria. Right, and again, what do we want to know about it? We want to know pathophys, signs and symptoms, how to diagnose and treat. Okay, that's what we want to know about every medical condition that we come across. Alright, our pathophysiology is a UPD deficiency, uroporphyrogen decarboxylase deficiency, and this enzyme in this problem actually results in an iron overloaded state. Alright, and what I mean by iron overloaded state is that, you know, this is going to result in excess iron laying around. Alright. And when excess iron lays around, it sort of damages tissues. Iron is a very heavily oxidizing agent. Iron, you know, as we use it, we actually use it to our advantage, you know, in heme when it's binding oxygen. But when it's oxidizing other tissues, that's not great for those tissues. All right, and so the problem with porphyria cutanea tarda is that it's like unlike acute intermittent porphyria, this is a chronic condition. Okay, this is happening all the time consistently, and that the problem is that when we inhibit our heme synthesis pathway, we result in extra iron getting left hanging around, all right, because the body needs that iron. You know, iron is sort of with the process the whole time, all right. Iron is hanging out, you know, it's waiting its turn, it's waiting to get incorporated into this heme molecule, you know, and if we stop the pathway right here, the iron is going to accumulate, all right, and so this is an iron overloaded state, all right. So the signs and symptoms of porphyria cutanea tarda, the two big ones are going to be skin blistering and photosensitivity. All right, skin blistering is a very is not a super common symptom, right? But photosensitivity is not super common either. And something that I would encourage you to do when you get these sort of uncommon symptoms is to look at different things that can cause those symptoms. Because if you see in a question the patient has photosensitivity to light or to UV light, I want you to immediately think about a couple of things, and that sort of helps you because that's going to limit down your differential for that problem. All right, so let's draw a little caveat over here and talk about photosensitivity. And we'll call it this is going to be our photosensitivity box. All right, so we're going to incorporate a couple of things. So pathologies that can cause photosensitivity, well, we've already talked about one, so that's porphyria cutanea tarda. Other things that can cause it would be SLE. This is systemic lupus erythematosus. All right, lupus is actually very well known for having photosensitivity to UV light, and in fact, a lot of charitable lupus foundations will have clothing for lupus patients. All right, that's sort of UV protective. All right, And that helps those patients out a lot if they're able to have those clothing items because it will block some of that UV light and block some of that photosensitivity. Another thing I want you to think about is called xeroderma pigmentosum. And xeroderma pigmentosum is a defect in repair of thymidine dimers or pyrimidine dimers. Right? And those thymidine dimers join up in DNA, and this happens every day. This happens to all of us every day. Okay, we get those thymidine dimers formed, but we all, those of us without xeroderma pigmentosum are able to repair those very easily. But if you don't have that repair mechanism, you're going to have a defect, and that defect is going to cause a rash, and it's going to cause a very highly increased chance of cancer. Right, skin cancers specifically. Alright, so those are things that can cause some photosensitivity. There's other pathophysiologies that can cause photosensitivity, but these are some of your top three. Alright, the other thing I want you to think about is drugs, alright? Drugs that cause photosensitivity, and mainly, these are going to be our antibiotics. Alright, so the big three antibiotics I want you to think about is going to be doxycycline, alright, sulfa antibiotics, and the last thing is going to be our quinolones. And I don't want to go too much into these antibiotics right now, but something I want you to think about for these, doxycycline is a protein synthesis inhibitor. Right? It's a pretty broad spectrum antibiotic that we can use for a lot of different things, especially atypical bugs. Right? Doxycycline is going to cause photosensitivity. Okay, sulfa antibiotics are folate pathway inhibitors for bacteria, and when we inhibit that folate pathway, that's going to help us fight a lot of those antibiotics. Something we think about is TMP SMX. That's one of our sulfa antibiotics that we're going to very commonly use for gram-negatives, or E. coli is another thing that we use that for. Right, and our quinolones are actually topoisomerase inhibitors. These antimicrobials are the fluoroquinolone class, and these are the oxacins. Alright, so this is ciprofloxacin, levofloxacin, moxifloxacin, and we're going to commonly use these for respiratory infections. Alright, so these are some other things that can cause photosensitivity. These things aren't especially related to porphyria cutanea tarda, but these are things that cause photosensitivity, and I sort of wanted to draw your attention to that. If you think about skin blistering, we can sort of draw a quick caveat over here, and talk about, bullous pemphigoid. Right, so that's something that can cause skin blistering. Burns can cause skin blistering. Right, and so a lot of our photosensitivity disorders can also cause some skin blistering as well. All right, so whenever you get these types of things, think about if you can narrow it down to a couple different things. If something causes a fever, you can't really narrow that down to a couple diagnoses. But some of these characteristic symptoms can really help you out, especially in a disorder like porphyria cutanea tarda. They can't give you a lot of vague symptoms in order to diagnose this condition. They have to give you something that will cue you into what this condition is. So they have to give you something, sort of descriptive of that condition, and that's going to be this photosensitivity a lot of the time. All right, we're going to diagnose this with urinary porphyrins. All right, we're going to diagnose a lot of our porphyrias with urinary porphyrins. We can also use gene analysis for this. Okay, and urine is going to turn dark in UV light, and that's sort of our Woods lamp. All right, that's specifically the Woods lamp. So if we looked at this urine under a Woods lamp, we would see that those porphyrins would fluoresce and they would turn purple under a Woods lamp. All right. So our treatment for porphyria cutanea tarda is very not relevant for STEP. I included it here for completeness sake. All right, we're going to want to limit estrogens, all right, and alcohol and smoking. That's just very commonly good recommendations for a lot of pathologies, but this in particular. All right, we're going to do phlebotomy for this. This is something we do for iron overloaded states. All right, this is going to decrease the total body iron storage and hopefully stimulate this pathway a little bit as well. If we try to take some blood out, we need more heme. Hopefully it's going to stimulate the couple of enzymes that we do have working in the body. Okay, hydroxychloroquine is another treatment that has been proposed for porphyria cutanea tarda, and that doesn't really relate to its pathophysiology, and that particularly is why it's not very relevant for STEP. STEP is very heavy on pathophysiology and sort of being able to understand the nature of disease, and this doesn't really relate to that, so we're just going to ignore that for now. All right. So now we're going to move on and make our copper porphyrinogen 3. Okay, that's what this uroporphyrinogen decarboxylase enzyme will do. Okay, and then thankfully we're nearing the end of the pathway now. We're sort of getting to the final bit of the pathway that's very relatable, very important for the pathway. All right, so copper porphyrinogen 3 is going to move back into the mitochondria here. All right, and that's going to be protoporphyrinogen. We're going to make that into protoporphyrin 9, and we're going to finally make that into heme. This is what we've been waiting for the whole time. This is the grand finale, finally, of the pathway. We're going to make that into heme. All right, and the enzyme we're going to use here is called ferrochelatase. All right, and so remember earlier how we talked about how lead is going to be important for the pathway? Well, lead is going to inhibit ferrochelatase along with that diala dehydratase that we talked about earlier. All right. The important thing about ferrochelatase is that this is a very important enzyme in this step in the process, and ferrochelatase is going to be very heavily inhibited by lead. All right, so lead is really going to knock out ferrochelatase. In addition, it's going to knock out diala dehydratase, but much more is going to inhibit ferrochelatase. All right, so something I wanted to talk about a little bit quickly with you guys is lead toxicity. All right, there's a lot of different heavy metal toxicity. Lead is one of the heavy metals that we'll talk about. Other heavy metals being mercury or gold. Some of those other metals that the body doesn't have a huge availability, doesn't have a lot of options to do with those things, and they'll accumulate in tissues. All right, pathophysiology for lead. This is going to be our sources. Sort of where do we get lead poisoning from? Well, we get it from old houses, and that means old paint. All right. Kids frequently get it. Kids chewing on the windowsill is sort of a classic description. Batteries is another place we can get lead from. Ammunition, so like for guns or for explosive ammunition, sometimes we'll have lead in them. All right, signs and symptoms. So signs and symptoms of lead are sort of very characteristic. All right, wrist and foot drop. All right, is going to be a very common description of lead. I want you to remember that. All right, encephalopathy. That just means confusion, altered mental status, sort of an acute nature. All right, this is going to be a problem with lead poisoning. Okay, and this isn't very descriptive of lead. All right, lead colic. All right, this is going to be a GI problem. All right, so we think about lead colic being abdominal pain. All right, abdominal pain and encephalopathy. All right, lead nephropathy. Okay, I don't know if you noticed this yet, but lead is going to affect a lot of our internal organs. All right, so lead nephropathy is going to be a problem. So you're going to get some kidney failure from this. It's going to cause anemia because it's inhibiting our heme synthesis pathway. Another thing I want you to think about is something called Burton's lines, and we're really moving away from trying to use descriptions of people's names, these sort of eponym descriptions of disorders. These are going to be blue lines on the gums. Okay, in the mouth, right? So you can see these sort of lead lines on the mouth, all right? The other thing that we'll see is one way to diagnose lead toxicity. Another thing we can do is get a lead level, all right, in the blood. But something else we can do is take an X-ray of some bones, and we'll see the lead lines, which are these sort of lines in the bone, sort of in the metaphysis of the bones, and they'll sort of look like this, all right, in the bone. Okay, so if we sort of drew sort of a generic bone here, we'll see lead lines sort of at the top of the bone like that. All right. Our treatment for lead toxicity is going to be something called succimer. All right. Succimer we use a lot in children for lead toxicity. All right. And dimercaprol is another one that we'll use, and an EDTA. And these are very common chelating agents. These things sort of, if we sort of have that iron hanging around, these things are going to sort of bind it, hang around it, hopefully get excreted. That's sort of the goal of our treatment of lead, is to bind it and get rid of it. All right, so that's lead toxicity for you. All right, so we've sort of finished up our pathway now. I want to put a couple finishing touches on the pathway, sort of clean it up a little bit, and I want to draw your attention to one last pathology here. All right, and sort of left a big space in the middle, and the space in the middle is something I want to talk about: sideroblastic anemia. Right, so we'll talk about sideroblastic anemia, and then I want to leave you with a final sort of fun thing about the pathway, sort of end on a good note. All right, so sideroblastic anemia we're going to talk about more when we talk about anemias. The sideroblastic anemia is very relevant here because all of these things are going to cause sideroblastic anemia. Specifically for B6, it's going to be a deficiency. Okay, we think about lead is going to cause sideroblastic anemia. All right, and alcoholics. Your neighborhood alcoholic, again, really getting beat up. This is going to be a problem again with alcoholics. All right, so what do I mean when I say sideroblastic anemia? Well, let's actually make it red. So let's draw a red blood cell. All right, and this is going to be a precursor red blood cell. It's still going to have a little bit of a nucleus. It's still going to have some mitochondria floating around. All right, and what we're going to get in this red blood cell is iron accumulation. Alright, we're going to get it in little rings like this. Alright, we're going to get it sort of building up here, building up here. Alright, and we're going to get something else as well. We're going to get a lot of little purple stains as well. So let's talk about these two different things. So these are two different symptoms. The blue is going to stain with a particular stain called Prussian blue. And that stains, you guessed it, iron accumulating around in the cell. Alright. Iron is not stained by our normal H&E stain, it's going to be stained by Prussian blue. All right, so Prussian blue is staining this iron left around. Remember how we talked about in porphyria tarda how a lot of these things that cause defects in the pathway are going to cause an iron overloaded state. All right, and that's gonna be hanging out here as well. All right, and in the cell it's gonna be accumulating. Okay, and it's waiting to get incorporated into the heme. It's patiently waiting in line, but if we have a problem with our heme synthesis, it's going to build up in the cell. All right, so we can stain that with Prussian blue, and that is called ringed sideroblast. The other problem that we get in these precursor red blood cells is something called basophilic stippling. And this is really, the buzzword of buzzwords. Basophilic stippling is a very common buzzword for lead poisoning and lead toxicity. All right, and so basophilic stippling results is because of little RNA molecules that get grouped up and bunched together, and that is caused by lead in particular. All right, so lead is going to be causing a basophilic stippling. All right, and so they'll in a question, they'll give you sort of a description of somebody with lead toxicity, and they'll say on blood smear, they have these little, and they'll show you a picture, and they have these little purple dots in the red blood cell, and that's basophilic stippling. Okay, and so this is a sideroblastic anemia, and this is a problem with heme synthesis, and it really fits nicely with the pathway that we talk about sideroblastic anemia now versus later is now you can really picture it in the middle of the pathway. Sideroblastic anemia, is the grand reveal of this pathway. This is the grand pathology that we're going to get. The most common heme synthesis pathway anomaly is going to result in sideroblastic anemia. Alright, so that's pretty much it for the pathway. I want to leave you with one final little anecdote, and that's about porphyria cutanea tarda. And this is sort of a mythology thing, but porphyria cutanea tarda is thought to be sort of the vampire's disease. If I can spell it right, this is going to be the vampire disease. Alright, so the reason for this is because, classically, vampires are scared of sunlight. Okay, and so that's kind of a fun little thing. These porphyria cutanea tarda, every time they go out into the sun, they would get blisters and that sort of thing, and so they'd be afraid of the sun. They'd be very pale people. They'd be very pale individuals because they don't go out in the sun very often. And the other thing is that, they would drink blood. Okay, and this is sort of an ancient thing, but, these people were very pale, and sometimes they would be very anemic as well. And they'd get very they're very pale, and not only because they're not going out in the sun, but because they're not have a lot of blood in their body. They don't have enough hemoglobin, making that sort of red pinkish color. Okay, and so maybe an ancient cure for this was thought to be blood, and that actually didn't really end up working out that much. Because they thought, maybe if you drank the blood, it would go directly into your bloodstream, and that's not really how it works, but this is sort of a mythological origin for vampires. I think that this has been disputed, but this is sort of a fun little anecdote. Porphyria cutanea tarda is the vampire's disease. The silver stake thing, I'm not really sure where that came from for vampires. It definitely didn't come from porphyria cutanea tarda, but just a fun little anecdote to sort of end our discussion of heme synthesis. So next we'll move on into talking about hematopoiesis and the different blood cells and where they come from. That'll be a relatively quick discussion, and then we'll go into anemias, which is a huge discussion, a big discussion on the different types of anemias and how we classify them, and that's going to be very important for a lot of different organ systems as well. So I'll see you for that.